Oke, YouTube.
Recording in progress.
Alright. Assalamualaikum warahmatullahi wabarakatuh. Hello, hello. Good afternoon and evening, Indonesia. Good morning, France. And good day for our friends from all the rest of the world. It must be evening and night in Pacific, Australia, in New Zealand, afternoon and evening in Asia, morning now in Europe and Africa, and night in North America, Central America, and South America. First and foremost, thank you everyone for coming. Welcome to this international webinar that is attended by participants from many countries of 6 continents around the globe. We are gathering this day, all nations, citizens of the world, to be united for helping the people against blindness. Welcome to our 26th episode of Distinguished Maestro Lecture. I am Gede Pardianto from Indonesia. Let's start the webinar. To honor the origin country of this webinar, please pay attention to Indonesian national anthem. Thank you so much. And to honor the origin country of our distinguished speaker, please pay attention to France's national anthem. Thank you so much. Ladies and gentlemen, the great maestro this time will be Professor Antoine Brezin, a master, a friend of mine, a multiple awards winner, an international author, and a world-class eye specialist. Professor Brezin chairs of the Department of Ophthalmology at Université Paris Centre d'Ophtalmologie Hospital de Paris, Hospital Pusat, Paris, where more than 10,000 procedures are performed each year, and which rank #1 among French hospitals for cataract surgery. He has participated at many international projects in the field of intraocular inflammation and cataract surgery. Professor Brezin is the coordinating author of textbook of uveitis published by the French Society of Ophthalmology, and he authored more than 200 publications in the most prestigious journal on earth, including the New England Journal of Medicine, the Lancet, Archive of Ophthalmology, American Journal of Ophthalmology, British Journal of Ophthalmology, Investigative Ophthalmology and Visual Science, Nature Clinical Practice Rheumatology, Arthritis and Rheumatism, etc. Now, he is going to deliver the Maestro lecture to hundreds of participants from many countries of 6 continents around the world. Wow, that's very marvelous. At this very moment, he will present a very important topic with the title Cataract Surgery in Uveitic Eyes. It will be a really breathtaking topic. Now, we are learning from the man who is a grand maestro on this field. So be prepared. Fellow ophthalmologists, let's pay attention to Professor Antoine Brezin. So Antoine, we are counting down for you. 5, 4, 3, 2, 1. Time is yours. Lift off. Applause. Godspeed, Antoine Brezin.
Thank you very much, Gede. It's a great honor. I hope I'll be up to such an incredible introduction. It's a first for me, and I'm very, very happy to be with you. Afternoon, your time, morning, my time. And as you say, you know, cataract surgery in uveitic eye is a complex topic because it associates our surgical skills with our medical skills, and it's all about the beauty of ophthalmology, where we are doctors, medical doctors, and surgeons at the same time. So what I'm going to address today is really the different situations we can encounter when we're dealing with cataract surgery in uveitic eyes. And the first thing we have to realize that the situations are really truly heterogeneous. There is no such thing as the one-size-fits-all rule that would accommodate for all situations that we encounter in ophthalmology. I'm just checking that. Yes, okay. Please confirm that you can that you really are hearing me fine, that there is no problem.
Yes, very
okay,
fine.
Great. So there is no single rule that would apply to all the different situations. What I'm showing on this slide is a variety of situations. And you have on the left a situation with Fuchs heterochromic cyclitis. This is at the center a patient who has sarcoidosis. In the bottom here in the center, this is a patient that has juvenile idiopathic arthritis. And on the right, it is herpes. You see the transillumination of the iris. So it's a chronic herpetic uveitis. All these situations are different. And even within these contexts of different diagnoses, you have many different cases. Some patients have had active recent uveitis. Some patients have had long-standing. Some patients did not have an attack for several years. So because of this heterogeneity, I truly believe that each individual situation is different. And there is no such thing in the field of uveitic cataract surgery as evidence-based data, because precisely you cannot mix apples and bananas. If you analyze your results and you're mixing such different situations, really the results are quite meaningless. So a lot of what we're doing in the field of cataract surgery of uveitis is not evidence-based, it's experience-based, and a lot of the decisions are empirical. As a caveat, I will just say that I will not address today the subject of idiopathic arthritis, juvenile idiopathic arthritis, of cataract surgeries in children with uveitis, because this is a specific topic and it's more in the field of pediatric ophthalmologists and uveitis specialists. In my hospital, we are not operating children under 15 because it's separated between adults and children. And mostly when we're dealing with children with uveitis and cataract, the problem are different. There are the problem of amblyopia prevention. It's a whole different field, and I will not address it today. So in terms of cataract and uveitis, Murphy's laws apply. Anything that could go wrong will go wrong if we're not doing things properly. I'm showing here two examples of patients who have been operated on while the uveitis was uncontrolled. And you see the horrible results on both cases. Here you have deposits really all over the IOL. So there's been some trial to improve the situation by doing some YAG laser over that membrane that is lacquering the anterior face of the IOL, but really the outcome is very poor. And this is even worse. It's not a cataract. This is a white deposit over the anterior surface of a lens. And you see a beginning also of band keratopathy. So these are really horrible examples of things going wrong because the management has not been correct. And it's even worse than that. These are patients that I've seen that had been operated elsewhere for cataract surgery in uveitic eyes, and you can see that here you have you see the placement of the lens, and probably here I think they've tried to open the iris and then resuture the iris, and that led to a horrible inflammatory reaction. And again, you have these white depots on the anterior segment on the anterior surface of the lens. You have pigment here, and the visual outcomes are horrible. You have some intermediate outcomes, and this is really not so great. And this really shows that we are due to do better. And our uveitic patients who already have a chronic disease, when the time comes and their disease is complicated by cataract, we have to do the best we can, and we really have to control the inflammation in addition to perform the perfect surgery. So the challenges of cataract surgeries in uveitic eyes are multiple. The first one is the preoperative assessment. How is our patient doing? And we really have to know what's going on behind the lens. It's sometimes difficult, but if there is uveitic macular edema, such as this in this example, we really have to control the inflammation, because if we don't, we might do a very nice surgery, we might be very proud of ourselves, but the visual outcome is going to be terrible for the patient. So controlling, knowing what's behind the lens, controlling the inflammation prior to the surgery is an absolute requisite. You can't just decide, yes, we're going to operate and we're going to see afterwards. Of course, in some situations, it is much more difficult. If you have a white cataract, you don't really know whether there is macular edema. But if the disease is bilateral, at least you can try to assess what's going on in the other eye and make your decisions on that. And also, if you have the diagnosis, try to adapt the treatment according to the general knowledge linked to the underlying diagnosis, etiology of the uveitis. But you can't do a blind surgery not knowing what's going on, and at least not trying to know what's going on behind the lens. So this means that you have to adapt the pre-op treatment to really bring your eye to a quiescent stage before operating. What kind of pre-op treatment can we use? If the inflammation is uncontrolled, we have several solutions. One is to increase the systemic treatment. The other one I use very often is to use a subtenon injection. And you see here an OCT example of the rather quick effect of a subtenon injection. And of course, you can also use intravitreal dexamethasone. And we're using a lot the long-release dexamethasone implant, Ozurdex, in this kind of situation. So and it can be a combination of increasing the systemic treatment and intra or periocular corticosteroids, but definitely you cannot go ahead and do the surgery if you haven't brought the eye to the most quiescent situation you can achieve prior to the surgery. When should the surgery be scheduled? That's another area where there is no evidence-based data because, of course, there's never been a randomized study where 100 patients would be operated, let's say, 1 month after an attack of uveitis and another 100 3 months later, and there would be a prospective comparative follow-up to verify that the fact that you have to wait. But there is a consensus among uveitis specialists that a 3 months preoperative quiescent period is required. If you've had an uncontrolled attack within the 3 months prior to surgery, do not go ahead. First, adjust the systemic and or the local treatment in order to bring the eye back to a quiescent stage before you do anything surgically inside that eye. What you see here in the upper left is a patient that has had an arterial occlusion in the context of Behçet uveitis. Of course, if the disease is uncontrolled and the patient has cataract, do not operate. Again, here you see a macular edema that can be in most etiologies, in most causes of uveitis. Here you see heavy leakage, papillitis of all the vessel at the posterior pole. You must control that inflammation if you have a cataract at the same time. And you have here an attack of B27 uveitis with a huge fibrinous deposit in the anterior chamber. And you have, again, to have brought that eye to a quiescent stage and maintain that quiescence during at least 3 months before you can envision to do the cataract surgery. This is just an eye that I saw yesterday. This was a patient that came from another country, and he had been operated while his inflammation was uncontrolled, and you can see the horrible results. And that patient was legally blind. You can see that the cornea has suffered from the surgery, that the iris has been ripped. I don't really know where the IOL placement is here, but definitely you see a rhexis. There's been shrinkage of the rhexis, and here you have a capture of the iris that is beneath the IOL. So clearly, again, everything that could go wrong went wrong, and that was especially because the patient telling me that he still had active red eyes at the time they performed the cataract surgery. They hadn't controlled the uveitis, and the results are just terrible. So usually, once you've achieved that and you've achieved control of the inflammation and you've waited long enough and verified that the eyes are remaining quiescent, really what the most people are discussing in terms of cataract, thinking about at least in terms of cataract surgery in uveitic eyes, is how do you deal with the synechia? How do you deal with these post-inflammatory adherences between the posterior face of the iris and the anterior capsules? And I would say that it's no big deal. I mean, that's not really the issue. The issue is really what I was telling you before: control the inflammation. The rest is not that difficult. We have 3 main categories of solution to deal with an undilated pupil in the context of uveitis. One is hooks, and you can see here 4 paracentesis bringing, and you see this enlarged pupil. You can use rings. The most commonly used rings is the Malyugin rings, but there are other rings, and there are very clever devices to maintain the pupil dilated. And there's my favorite because it is the simplest, which is Beeler's pupil dilator, and I will show many images of this. So let me start with this case. It's a 60-year-old male who has the history of sarcoidosis. He'd been quiescent for several years, and you can see his pre-op image here. The patient had 20/50. He had a grade 2 cataract, and I was unconcerned about a relapse of the inflammation because his sarcoidosis had been quiescent for years. So what I'm using is local anesthesia. It's topical oxybuprocaine. It is complemented by an injection. Sorry, 1 second. Yeah. It is complemented by an injection of midraine at the beginning of the surgery. I'm using the Centurion phacoemulsificator. I use a 2.2 main incision, a side port, my viscoelastics or Duvisc, and the settings are very, standard settings. I don't have to really adjust anything for cataract surgery. We'll talk about IOLs later, but in this patient, the implant I used was the Clarion 22 diopters. So let's go ahead and see how it's going. You can see here, it's just the usual. I'm doing a clear corneal temporal incision. Again, as I was saying, 2.2, I'm injecting the viscoelastic, and you will see that already you can do a lot with the viscoelastic cannula. I'm breaking the synechius here, and already you've seen that the pupil has significantly enlarged. So now I'm introducing Beeler's pupil dilator. The two branches, there are two models, one with 3 branches. This one has 2 branches, and you can see that I can stretch the pupil. I'm doing this under topical with the midraine injection, and really the patients usually feel nothing or really a slight, very moderate pain. At the time we dilate the pupil, I'm re-injecting viscoelastic here. You can see that there is some very moderate bleeding at the pupil edge. And you've transformed what seemed like a difficult surgery with the synechius into a very standard cataract surgery. Have enough space to perform the capsulorhexis. In the context of uveitis, you have to do a large enough capsulorhexis because sometimes you see post-inflammatory shrinkage of the rhexis, which can lead to capsulophimosis. So, I'm speeding up. I'm not showing you all the stages, but basically we've transformed what was seemed like a difficult surgery at the beginning, with the synechius into a very standard surgery. I'm just going to go ahead and do a very standard divide and conquer surgery. Nothing fancy here, very, very smooth and standard surgery. You can see that the pupil remains dilated. There is no, the pupil doesn't constrict again. The stretching has been sufficient to maintain a good pupil dilation. And I will show you later in different cases how the postoperative pupil looks like. But you can really see that in this kind of situation, you do not need a ring or hooks. The fact that you've done this pupil stretching with the Beeler dilator was enough. And you can see that as I am removing the pieces of nucleus, the pupil remains dilated. And again, I'm doing all this under pure topical. There has to be very good attention paid to the removal of absolutely all cortical fragments. If you leave any piece of cortex, you are creating the conditions for recurrences of inflammation. Once I've had a perfectly clear bag, I implant. Here is a Clarion lens from Alcon with the autonomy injector. We'll talk about IOLs in the context of uveitis, but again, it has to be, in my opinion, a hydrophobic lens. And you see here the final picture at the end of the surgery. There were some bubbles after I used the BSS to make the incision, a self-healing incision by injecting BSS around the wound. So the case summary, overall, the cumulative dissipated energy in this case has been moderate. The advantage I like with this machine is that I can use only torsional, which spares a lot the endothelial cells. And overall, the aspiration time has been really minimal. And these cases are quick, they're simple. They're actually, once you've dealt with the synechias, which was, as you've seen, no big deal, they aren't that complicated. In other cases, this is a case that has had to have a peripheral iridectomy because there was the synechias were 360 degrees. You have to remove a cyclitic membrane. You see that here the pupil is even smaller. It looks like it's going to be a different case, a difficult case, and you will see that it's not that difficult. Again, the same principle. I'm taking time to break the synechias. Again, you see the eyelids moving. I'm under topical, and as I'm breaking the synechias, you see that in fact you have a cyclitic membrane, and the synechias are not just at the pupil edge; they're way below the iris. So I'm using my second hand here with a micro manipulator to be able to really address the synechias 360 degrees. You see, we start to have a light pupillary reflex, and I'm going to pull the cyclitic membrane out just with my capsulorhexis forceps. And you can see that the situation now is already way easier than it was 1 minute ago. Again, I'm using Beeler's pupil dilator here, and I'm going to do the iris stretching. And now, as I will re-inject the viscoelastic, you have to be careful here when you remove it so that you don't grasp the cornea endothelium. I'm re-injecting viscoelastic, and you can see that we've transformed what seemed like a very difficult case with a small pupil, no orange reflex, with now what is going to be a very standard case, and we're going to be able to perform a large size capsulorhexis and just go ahead with the surgery. So again, it's all about taking care, preparing the conditions in order to do a standard surgery. These are side views from the Beeler pupil dilator. It's a very neat instrument, and it's also has the advantage of being inexpensive because once you've bought it, you can reuse it as compared to other disposable devices. So this is a typical situation where you have a pre-op, post-op. On the upper left, you have the pre-op situation, and I'm showing you undilated. So you see there is some small traces here at the pupil edge of where the Beeler's pupil dilator has been applying pressure on the pupil. But overall, it's quite neat. And if you dilate the patient, this is what you see. There is, again, if you've managed the inflammation properly, you do not see any deposits on the surface of the IOL. And again, that requires good control of the inflammation. I'm going to go show you a few other cases. They're all in the same principle. Again, breaking the synechias here. And once that is done, you introduce the pupil dilator, go ahead, stretch smoothly, not too quickly. You know, you don't want to rip the sphincter, retrieve the instrument and re-inject viscoelastic. And again, you've transformed what seemed like a difficult case into a simple one. Another example here, and I've got, I don't know how many dozens, I'm just, I've selected some. So just to show you that you should not be stressed by the fact that the pupil is undilated. You use your two hands, break the synechias, try to go as far as possible because sometimes there is adherence between just not at the margin of the iris, but between the full posterior surface of the iris and adherences with the anterior surface of the lens. Use the pupil dilator like this. Some people are just using two instruments or trying to achieve the same with using, for instance, two Sinskey hooks, but I don't think it is as smooth. I don't think you balance the pressure as well across different areas of the iris. There are some cases are even simpler. This one here, there are multiple synechias, and you can see that I will just go ahead, use the viscoelastic, and I won't even have to use the pupil dilator, because just pushing the iris away, breaking the synechias with the viscoelastic is going to be enough. And I will have a pupil dilation that will allow me to do the surgery without even introducing the pupil dilator. You see here, I've broken the synechias using my port side incision. And here now I have enough of a diameter to go ahead and perform the surgery. And you see here, I'm just going ahead. I haven't done anything else. And again, to show you the pupil remains stable. You have to be careful. They might be hidden pieces of cortex between a not fully dilated pupil, but so you have to go behind the iris and check that you removed every piece of cortex in order to prevent rebound inflammation. Now, this is the final stage. So I only use hooks or rings in extreme cases. This was a very extreme cases. You see the cataract is super advanced. The synechias are not just at the margin, but they're kind of everywhere. And I'm slowly, you see here, I'm using several hooks, and you have to slowly stretch the iris. Why am I rinsing here? Is because once you've done that, I'm going to have to use Vision Blue. And so I'm going to rinse, I aspirate the viscoelastic before staining the capsule with the Vision Blue, and then being able to perform the capsulorhexis. So these are the extreme situations where I use the Beeler's pupil, the hooks. This is another situation here. I've tried to use the pupil dilator, but the synechias were so much all behind the iris that I believe that in that case, I've had to use, you see, I'm stretching, but I feel that it's not enough. You see all these pigments, and the pupil doesn't stay as dilated as I would have wished. So I'm introducing a maluging ring to complement what I've already done. And again, you have to engage the 4 different parts that will push the iris and maintain it. So this is here I'm engaging. There is a special, I'm re-injecting viscoelastic. You see how many pigments are on the interior surface, and with the Sinskey hook, but there is a better instrument than that. I didn't have it on that occasion, but I'm pushing here the final place where I will place my maluging ring and maintain a sufficient pupillary dilation so that I can go ahead and perform the surgery. There are some other specific challenges. This was our old operating room. We have a much better, much nicer one now, but I don't have as good as picture. This patient had very advanced ankylosing spondylitis. And if we wanted to operate, there was no other way than installing him this way in the operating room. This can happen. You just have to adapt to the patient. You see how far up his legs were because he had absolute ankylosis of his cervical spine. There are some cases, again, as an introduction, I was telling you how heterogeneous the situations are. This is a highly complex case. 46-year-old patient. She has had bilateral uveitis with exudative retinal detachment, which was a side effect of an anti-cancer treatment by monoclonal antibodies, nivolumab. When we could still see the fundus, this was how she was. She had a VKH, Vogt-Koyanagi-Harada-like disease, which is a well-known complication of nivolumab. And When I had to operate her, both eyes were like this. So she had hypotonia. So her pressure was 5. I'm trying to put a bubble here to be able to stain and put vision blue, and the bubble won't stay because the anterior chamber is so shallow. So I'm staining here. The eye pressure is 5, and the globe has shrunk to less than 21 millimeter axial lens. So I'm trying carefully to avoid the Argentinian flag that can happen when you release active pressure within the bag. And you see that not only am I performing a standard rhexis, but at the same time, the rhexis is going to take away all the pigment deposits that are in the over the anterior capsule. And I'm taking my time. Please bear with me to perform the rhexis. I wouldn't show the whole thing, but here is once I've performed the rhexis, you see that you have these very white cataracts. They're very milky. Again, the challenge is to perform the to stain and perform the capsular rhexis without having the Argentinian flag. Then usually the phacoemulsification is rather simple. Once I've done that, you see that some remnants of pigments here at the margin of the capsular rhexis. I'm opening the capsular bag with the OVD, and it becomes a quite standard case, except that here the lens calculation showed, because of the hypotonia that was due to our syndrome, I would have had to implant a 40 diameter lens in order to achieve emetropia. So I implanted the greatest power I have, the largest power I have, which was 34 diopter. And I carefully, as always, removed the viscoelastic behind the lens. And you see here the final stage. I'm doing, in this case, I'm doing a subtenon injection at the time of surgery to really be sure that there is not going to be an inflammatory rebound. And that's something I do rather often, not as curative because I only operate in quiescent eyes, but if I have the feeling that the surgery by itself could be a trigger for an inflammatory rebound, I introduce I use a subtenon injection at the end of the surgery. So this was, both eyes were the same. She had, the situation was bilateral, and you see the pre-op, post-op images. She received a 34 diopter lens, and in spite of that, you see that she's still +5 and +4 here, and she went from complete blindness to decimal 0.2 and decimal 0.05, which was great for her because she was again autonomous after several months where she was absolutely blind. Nivolumab and VKH or VKH-like syndromes are something that are now well described. In our case, it was more like almost an ocular effusion, uveal effusion syndrome, but you can see that it's been described before. In her case, the trigger was she had a gut melanoma, which is kind of a rare localization of melanoma. It was very advanced. Her life was saved by the drug, but with the complication of this very severe uveitis and subsequently these total white bilateral cataracts with hypotonia and really a real shrinkage of her eyes. I will now talk about a specific entity which is really different from all other uveitis, but which is a common cause of cataract in the context of uveitis, which is Fuchs' cyclitis. Fuchs is a specific entity. It's really different. It's a disease that no others. And as you know, it doesn't respond to either systemic corticosteroids or local corticosteroids. In fact, it doesn't respond to anything. One of the specifics of Fuchs is when you operate, when you have hypotonia, and this was right after the incision, you have here at the periphery this bleeding, which is called Amsler sign, and which is kind of one of the hallmarks of the disease. It can happen at the beginning. Here, I've spared you the whole surgery, but I'm implanting a toric lens as this patient, and as I am removing the OVD, again, you see this tiny blinding here in the angle, and that is a very frequent sign. It's just, you don't have to do much about it. It's just there. It doesn't require a special to be addressed in a special manner. But usually, sometimes when you're not sure of the diagnosis, seeing the Amsler sites just confirms the diagnosis. When you operate in patients who have Fuchs cyclitis, there is what I call the corticosteroids postoperative paradox. As I was telling you a few minutes ago, Fuchs doesn't respond to corticosteroids. But however, if you don't give high dosage and prolonged topical corticosteroids in patients with Fuchs cyclitis, you get into situations like what you're seeing in the left. You can have many cells deposit, large cell deposits, depots on the lens. And these are old pictures because I'm not using 3 pieces anymore, but we're now preventing this much better. And these depots respond well to corticosteroids. Here you can see that we've used high frequency of corticosteroids drops, and we've really virtually cleaned the lenses. So it's really what I call the Fuchs paradox, because you have a disease that prior to the surgery doesn't respond to corticosteroids, but once you've operated, you're not only required to give post-op corticosteroids, but you have to give them long-term. And when you see depots on the anterior surface of the lens, they will respond to corticosteroids, and the best is just to prevent them by prescribing to your patients long-term corticosteroids in this context. Which brings us to the next question. Sorry, this will move on. The next question is, which IOL in general should we use in patients with cataracts and uveitic eyes? So when we're discussing about IOLs, there are several questions. The design, the material, should we use a monofocal? Can we use multifocals in patients with uveitis? Where do we position the lens? And should, in some situations, a posterior rhexis be performed? A long time ago, there were non-foldable IOLs who had heparin coating, and there were it was suggested that they would prevent the formation of depots or cells that would be adherent to the surface of the lens. They've been more or less abandoned. I know some companies are selling them. Really, I think what has been shown, and that's really experience-based, is you have to use a hydrophobic acrylic. If you put a hydrophilic, the danger is that if you have a post-operative inflammatory shrinking of the capsular rhexis or just of the whole capsular bag, the risk is you're going to have a intraocular folding of a lens that's going to be too soft. Moreover, if you implant a hydrophilic lens, it's well known that the rate of posterior capsular opacification is greater in hydrophilic, and you want to delay or even avoid altogether YAG capsulotomy in the patients who have had cataract surgery in uveitic eyes, and hence the properties of the hydrophobic lens are useful in this context. And again, I think all evidence, at least all experience, points to using a hydrophobic acrylic lens in the context of uveitis. The lens properties should be to be resistant to retraction of the capsular bag, to prevent depots on the IOL surface, and ultimately to prevent PCO. I am not implanting multifocal or even EDOFs in the context of uveitis because you never know how the posterior segment is going to be in the long term. And very often it's unilateral cataracts. So even in young patients in that situations, I resist using EDOFs or multifocal, and what I usually implant myself are monofocals. There's been some discussion whether it would have been better to implant the lens in the sulcus. I personally always implant in the bag. And the posterior rexus discussion is really very much a discussion for a pediatric ophthalmologist in the context of juvenile idiopathic arthritis. And again, as I was saying earlier, this is something that I am not going to address because really it's a pediatrics specific. Post-operative capsulophimosis can be an issue, especially in patients with sarcoidosis. It's a bit like what they have in their skins, when they have keloids formation, when they have a scar, you see the same. It can be very strong. And again, the way to address this is to perform a large enough capsulorhexis at the beginning of the surgery and to put in a lens that would resist the power of shrinkage of that post-inflammatory interior capsule in the context of uveitic eyes. What are the post-op treatments? I would say that there are as many post-op treatments possible, as there are different situations of uveitis, and it's really heterogeneous. You've seen one case when I was using, on the occasion of surgery, a subtenon injection. In some cases, we can inject Ozurdex. Here it's highly visible. You see that the Ozurdex the implant has been directly in the orange reflex. Usually you don't see it as well, and that's so much for the better in terms of vision for the patient. Sometimes I have to increase the systemic treatment. It really depends. And again, as I was saying at the beginning, and as I'm saying again and again, the situations are highly heterogeneous. You just have to adapt. Follow-up. They're different than the usual cataract. Okay, usually when we operate a cataract now, we see the patient again 1 week later, 1 month to prescribe the glasses, and that's it. With a patient with uveitis, it's different. If you abandon the patient and the patient has an inflammatory rebound, that can lead to horrible situations. You see here uncontrolled inflammation, band keratopathy, terrible deposits on the surface of the IOL, and of course, we should never forget that glaucoma, uveitic glaucoma might be another issue, and you have to control the eye pressure. And sometimes it goes all the way to having to perform filtrating surgery in this context when we have uncontrolled ocular hypertension. One thing that is important is that if you have hypertension and a uveitic eye, you should not resist using corticosteroids in spite of the ocular hypertension, because very often the ocular hypertension results from the inflammation. And anyway, you cannot, if you have to balance between controlling the inflammation and the ocular pressure, the number one goal is to control the inflammation. Later on, you will control the pressure. If needed, you can go all the way up to filtrating surgery, but the ultimate priority is to control the inflammation, and whatever it takes in terms of corticosteroids, including topical corticosteroids. What is the prognosis overall? Well, again, it is tremendously heterogeneous. You've seen horrible cases, you've seen beautiful cases. I would say that in 2023, tremendous progress has been made. This is an image of a patient I saw a long time ago. Our masters in ophthalmology, they would perform sectorial iridectomy in these cases. You see the scar of an extracapsular surgery, a sectorial iridectomy. There was no implant. And yes, the eye was quiescent, but the visual outcome was just terrible. I think we've made enormous progress We've tailored our approach to different situations. We have the instruments, we have the medications to prevent inflammation. And if we are, if the patient is in good hands, with experienced surgeons, I think that the visual outcome of a patient that has uveitis and whose uveitis is complicated by a cataract, taken in time with expert management, the prognosis can be excellent, but we have to be we have to follow these patients very well. They have to be monitored regularly. And if we do everything according to the book, we can give them a much better prognosis than what you're seeing in this photo. So thank you very much. It's been an incredible honor for me to be with you this morning for me, end of the afternoon for you. And I'll be very happy to try and answer any questions you might have. Thank you.
Thank you so much, Antoine. What a lecture, Professor Brezin. That was super phenomenal. Fellow ophthalmologists, now we are approaching the question and answer session. So Antoine, I will read its question for you. The first question from Indonesia. Excuse me, Professor, I want to ask about how to perform subtenon triamcinolone. Thank you, Professor.
So subtenon triamcinolone can be done at any time. It can be done before the surgery, during the surgery, or after. Usually, you use just small scissors. You cut, you do a tiny buttonhole, and then you have to have a special cannula. And I inject 1 ml, 40 milligrams of triamcinolone, and that's it. It's very simple. The advantage over Ozurdex, it's much less expensive. And you don't go inside the eye. So it, especially, preoperatively, there is no risk of endophthalmitis because you're not inside the eye. The other advantage of subtenon, it's long lasting. It will last 3 to 6 months, whereas the usual Ozurdex usually would have an effect during 3 months, but rarely after that.
Thank you so much. The next question from our friend from Iran, Dr. Morteza Mortaza-Vivar. In case of long-standing question, uveitis without systemic medication, do you recommend starting systemic steroid before cataract surgery?
So that's the answer to that is whatever it takes to have an eye that is quiescent, that has been quiescent for at least 3 months at the time of surgery. If that needs to increase or introduce corticosteroids before the surgery, well, then we go ahead. As a general rule, we don't like using more than 5 or 10 milligrams for long periods of times in patients with uveitis. So we will use whatever is needed as corticosteroid sparing agents, either classical immunosuppressants or biologicals. We used adalimumab, Humira a lot in the most severe cases of non-infectious uveitis. But the reply is whatever it takes to have a quiescent eye, an absolutely quiescent eye for a sufficiently long period of time prior to the surgery.
Thank you, Antoine. The next question. Do you consider peripheral iridectomy in case of uveitic cataract?
No, we don't do a peripheral iridectomy. You've seen these many videos. I'm confident that I will not have 360-degree synechias. Also, sometimes we see, if we haven't controlled the inflammation well, we can see some synechias between the iris and the capsular rhexis. But we follow these patients. We don't let that happen, or at less possible. And I consider peripheral iridectomy in this situation, during the surgery, not to be necessary, and it would have been one, painful for patients under topical anesthesia, and two, it would add a pro-inflammatory trigger during the surgery. So the answer is we only perform peripheral iridectomies prior to the surgery when we have a tomato-shaped iris, if you have 360 degrees synechias that are observed prior to the surgery, but we don't do it during the surgery.
Thank you so much, Professor. What is your opinion about starting topical steroid before cataract surgery?
So, yes, we do it sometimes. We have patients, for instance, we know from their history that if we stop the topical corticosteroids, they will have recurrences. An example could be a patient with sarcoid uveitis, and we know that this patient is quiescent if we maintain a long-term dosage of 1 drop per day of corticosteroids. So we will maintain that until the date of the surgery, and after the surgery, we will increase that to our standard post-operative regimen, which is usually 4 drops of dexamethasone per day. In other patients, like in patients that have very frequent recurrent attacks of B27 associated uveitis, we might decide that we're going to prescribe 1 drop per day of topical corticosteroids during the months preceding the surgery, to be sure that at the time we're bringing the patient into the operating room, we've done everything to prevent a recurrence. So yes, in some specific situations, we do not hesitate to prescribe topical corticosteroids prior to the surgery, and that can be from a few weeks prior to the surgery to even in some situations to several months.
And from Dr. Murtaza Vifar from Iran too, what is your preferred method of prophylactic steroid delivery at the end of surgery?
So the proper method of steroid delivery at the end of surgery, is that the question?
Yes.
Okay, so have you seen, I've shown you several situations. Some we're only using drops, some we were using subtenon, sometimes we're injecting a Nosardex. Sometimes we do that before the surgery. Occasionally, on the occasion of the surgery, I don't like that much injecting Ozurdex on the occasion of surgery, but it's quite often that we have a patient that has kind of refractory uveitic macular edema and a cataract. So I would inject an Ozurdex, for instance, 1 month prior to the cataract surgery. So the reply to the question is the situations are heterogeneous, and according to the heterogeneity of the situation, anything goes. It could be topical, it could be subtenon, it could be Ozurdex, or even in some systemic cases, it could be increasing the corticosteroids dosage given orally.
Okay, thank you so much. The next question, Professor, could you please tell the detail about post-op steroid on FU, and how often per day the drops are instilled, and how long and how to taper it up? Thank you.
As most of my answers, I'm going to start by it depends, because again and again, these situations are so heterogeneous. Having said that, usually because I only operate at eyes, in situations where we've made the effort, the preoperative efforts, the preoperative adjustment of the treatment regimen, that we are going to operate on quiescent eyes, because we've taken these precautions preoperatively, the postoperative corticosteroid regimen can be standard. And our standard is 4 drops a day in the first week, and then we decrease 3 drops, 2 drops, 1 drop. one of the main difference in the context of uveitic eyes is that very often we have to prolong this treatment. It is not uncommon for me in some situations of uveitis and cataract surgery to prescribe corticosteroids during 3 months, 6 months, sometimes a year. And I've had some situations where even that has to be prolonged. You know, usually the patients ask, what are the complications? There can be 2 complications of corticosteroids drops. One is cataract, but once the patient has been operated, by definition, that risk has gone away. The other risk is ocular hypertension, but, you know, either patients are responders or they're non-responders. If they are non-responders, we have a free hand to prescribe the topical corticosteroids.
Thank you so much, Professor. The next question from Dr. Aya Abdul Regal from Egypt. If there is chronic resistant pseudophakic macular edema, is there chronic resistant pseudophakic macular edema in complicated IOL situation like optic capture of one-piece sulcus implanted IOL? What to manage first, the CME or the IOL exchange? Thank you.
That's a very difficult question. I think it has to be both. You can't bring back the patient to the operating room if you haven't controlled the pseudophakic, the macular edema. So I think in a situation like that, my standard of care would have been either a subtenon or an intravitreal corticosteroid injection in order to as quickly as possible obtained the resolution of the macular edema. And once that is achieved, but even sometimes very quickly afterwards, go ahead and try to perform the IOL exchange or try to improve the anterior segment anatomy. But you can't do one without the other. And controlling the macular edema as quickly as possible is going to greatly influence the long-term visual prognosis.
Thank you, Professor. The next question from Dr. William Stevenson. How to evaluate uveitic inflammation under control before cataract operation, and how to achieve inflammation well controlled prior surgery? Thank you.
So how do we evaluate the inflammation and how do we control it? Is this the question?
Yeah, to achieve inflammation well controlled prior surgery.
So what are the criteria? Well, as we well know, some uveitic cases are systemic diseases, and they can be extraocular measures of how the disease is controlled. If you have Behçet's disease, if the patient has oral ulcers all the time, it clearly means his or her disease is uncontrolled, and you have to control the disease better. So there are the extraocular elements. Then there are the intraocular elements. If you can visualize the fundus enough, and geography is useful to see if you have vasculitis, of course, OCT to assess the macular edema. So you have really many parameters and cells in the anterior chamber, vitritis, and so on. So you really have to check all the boxes: extraocular manifestations, intraocular manifestations, anterior segment, intermediate and posterior segment. See how is the inflammation, and you have to have a green light in for all these parameters. If the light is still blinking orange or if it's red, do not go ahead. Wait until you've controlled the inflammation before performing the surgery. Now, how do you control the inflammation? It's really disease dependent, and it's even case dependent, because again, even with a single entity, you can have different situations. It's just increase the systemic or the local treatment to the level where you will get a quiescent eye, and maintain that at least during 3 months before the surgery. That would be my global answer.
Thank you so much, Professor. Do you still have time?
Let's say we quit at 15 past the hour. Would that be okay? That will give us an extra 9 minutes.
Okay. Okay. This is the question from Dr. Muhammad Amin Zagreb from Algeria. Do you have prescribed both corticosteroid and SID post-op?
Yeah, I know the industry a lot is pushing toward non-steroidals. They might have indications. I think they're really too weak in the context of uveitis, and I don't think they bring anything in addition to the corticosteroids. So I'll have a clear answer. The NSAIDs are not with, I do not use NSAIDs in the context of uveitis. You need corticosteroids.
Thank you, Professor. The next question from Dr. Kautar Borik from Morocco. When is it better to switch to immunosuppressive drugs before surgery in a patient on corticosteroid therapy? And the next question, if we don't have access to the eye fundus, are there any additional measures to take? Thank you.
So you'll have to repeat the second question, but I'll start with the first one. The usual rule for prescribing immunosuppressants if a patient is uncontrolled with 10 milligrams of corticosteroids, then you cannot leave a patient long-term with more than 10 milligrams. And even some investigators, and I tend to be in that category myself, believe that 5 milligram long-term is the max that you can give in a patient for the long-term. Because if not, you will get all the complications of corticosteroids. You will have diabetes, osteoporosis, skin problems, and so on, infections. So you have to bring the patients under a long-term dose of 10 milligrams, if possible, 5 milligrams. That requires corticosteroid sparing drugs. Immorel, azathioprine is one of the most commonly used. It has the advantage also to be, it's possible to use it in women of childbearing age. And then mycophenolate mofetil is very often used, methotrexate in the context of sarcoidosis. And again, in the most refractory cases, we use biologicals, and the first line is adalimumab or Humira. So again, it's adapting the treatment to the level of inflammation and to the general diagnosis. Could you repeat the second question?
If we don't have access to the eye fundus, are there any additional measures to take?
Okay, so if we don't have access, I usually do ultrasound to check that the, at least I need it anyway for the IOL power calculation. So ultrasound is going to be important, and it's going to, I'm going to be able to globally assess whether there is vitritis or whether there is a thickening of the choroid, in some extreme cases where there's retinal detachment. In these cases, you cannot do better than using an ultrasound. But again, you're, and I try to base my assessment very much on what I see in the other eye. But these are the most difficult situations, I reckon.
Thank you, Professor. The next question from Dr. Hani Ibrahim from United Kingdom. Do you think there are differences between prednisolone and dexamethasone? I saw some AAU patient not responding to prednisone, but respond well to dexamethasone. Thank you.
Yeah, in France, our standard drops, if we're talking about drops, we're using dexamethasone drops. They're not available in all countries. The Americans, they use Pred Forte rather than dexamethasone. I do believe dexamethasone is stronger. So if you have access to dexamethasone, so much for the better. But it's whatever is available. And again, adapt the dosage to control the inflammation.
Thank you so much. Maybe this is the next question from Dr. Morteza Mortazavi Fark from Iran. What about topical mydriatic cycloplegic drops after surgery and NSAID drop after surgery? Do you recommend routinely?
So that's a very good question regarding mydriasis. So I very often prescribe atropine, which we never prescribed in other contexts usually. But when I've been using what you've seen with the Beeler pupil dilator, I tend to be, I don't want the pupil to constrict again. I want to prevent synechias between the iris and the capsular rhexis. So usually at the end of surgery, I put 1% atropine just at the time of surgery. And then afterwards, when I see the patient again, usually I don't prescribe mydriatic drugs, but I've just done that at the end of surgery. NSAIDs, non-steroidals, I've just replied before, I don't use them. I don't think they bring anything in addition to the corticosteroids. I know that the industry would like us to prescribe them much more, but I do not.
All right. So fabulous. Many questions have been answered by our super maestro at this very moment. Great speaker, great audiences, and so exceptional. Well, thank you so much. Thank you so much. Here we are spreading love, care, peace, and tranquility on earth. Thank you, SMAC Group. Thank you, ID, Perdami Sumut, Veron, Anak Sudarti Foundation. Thank you all committee, Dr. Diah in Medan and Hafiz in Jakarta, Indonesia. And thank you so much our distinguished participants. You are so gorgeous, so great. And to our Maestro Professor Antoine Brezin, please send our regard to your family. Thank you so much, Antoine. Merci beaucoup, Professor.
Thank you. Well, I must say it's been a great pleasure. I was very honored that there were so many of you that were listening to this, and it's really fun to think that people are all over the world. So it's very nice taking questions from different participants from different countries. I think medicine truly, as you say that in your introduction, is a field that that unites all of us. I've been very happy to be with you today. And I will wish you, because we're still in the beginning of the year 2023, a wonderful year 2023. Hopefully with peace everywhere. We have Europe is a complicated continent at this moment, and we hope we'll have peace soon. I wish you a very good year 2023.
Thank you so much. You are absolutely awesome. Have wonderful years, Professor.
Okay, thank you very much. Have a good day. Have a good evening to everybody. Bye-bye.
Thank you. Bye-bye. And our distinguished participants, thank you so much for your very loyal participation. And furthermore, the certificate for this webinar will be sent hopefully before 2 weeks. And your participation is highly appreciated. See you all. Happy New Year. Have a wonderful year of 2023. To all our friends from all the rest of the world. Thank you so much. Wassalamualaikum warahmatullahi wabarakatuh. Thank you. Bye-bye.
sensasional, pelayanan berstandar internasional, terlengkap nyaman bagi pelanggan, terjangkau tak memberatkan, teknologi terkini, dokter berkompetensi, Maestro selalu terdepan. Mari oftalmologis bergabung bersama, Maestro masa pilihan semua, berikan pemeriksaan mata bermutu, kepuasan pelanggan yang nomor satu. Mari oftalmologis bergabung bergandeng tangan, menghadapi masa depan, tuntaskan buta katarak di Indonesia, menuju Indonesia maju sejahtera. Smack Group majulah, Smack Group jayalah, Smack Group pilihanku, Smack Group tumpang sapu. Smack Group pusat kesehatan mata, rumah sakit kebanggaan kita, modern, mutakhir dan profesional, pelayanan berstandar internasional, terlengkap nyaman bagi pelanggan, terjangkau tak memberatkan, teknologi terkini, dokter berkompetensi, Maestro selalu terdepan. Mari oftalmologis bergabung bersama, Maestro masa pilihan semua, berikan pemeriksaan mata bermutu, kepuasan pelanggan yang nomor satu. Mari oftalmologis bergandeng tangan, menghadapi masa depan, tuntaskan buta katarak di Indonesia, menuju Indonesia maju sejahtera. Smack Group majulah, Smack Group jayalah, Smack Group pilihanku, Smack Group tumpang sapu.
Optimax Premium, satu-satunya suplementasi mata di Indonesia dengan formula yang sudah sesuai dengan studi ARETS 2, sehingga sangat tepat untuk mengatasi degenerasi makula atau AMD. Optimax Premium mengandung lutein dan zeaxanthin dengan rasio 5:1 yang terbukti efektif dalam menahan laju keparahan AMD. Lutein dan zeaxanthin merupakan beta-karoten yang paling banyak terdapat di makula, yang berfungsi sebagai antioksidan dan pelindung makula terhadap radikal bebas. Dilengkapi dengan vitamin C dan vitamin E sebagai antioksidan kuat yang dapat mencegah kerusakan sel dan jaringan akibat radikal bebas, termasuk menjaga sel mata. Serta mengandung zinc sebagai antioksidan yang banyak terdapat di retina yang dapat melindungi retina dan menurunkan resiko dari kerusakan retina. Apa hasil penelitian dari formula ARETS 2 terhadap AMD? Dengan formula ARETS 2, terbukti menurunkan risiko degenerasi makula sebanyak 43% dan menahan laju keparahan dari AMD tipe kering menjadi AMD tipe basah sebesar 31%. Lebih baik dibandingkan dengan formula ARETS yang pertama. Optimax O3, satu-satunya suplementasi mata dengan komposisi yang sesuai untuk dry eye syndrome. Optimax O3 mengandung omega 3 yang sudah direkomendasikan oleh American Academy Ophthalmology untuk mengatasi dry eye syndrome. Berfungsi dalam meningkatkan produksi air mata dan meningkatkan kualitas dari air mata sehingga tidak mudah menguap. Dilengkapi dengan lutein dan likopen sebagai antioksidan untuk melindungi mata dari radikal bebas. Optimax 4G membantu mengoptimalkan terapi glaukoma. Mengandung bahan alami yang terstandar yaitu mirtogenol dengan campuran komposisi mirtoselect yaitu ekstrak bilberry terstandar dan picogenol yaitu ekstrak kulit pinus terstandar. Mirtogenol berfungsi untuk menurunkan tekanan intraokular pada mata dan menjaga kesehatan sirkulasi darah pada mata. Mirtogenol sudah terbukti bekerja secara sinergi bersama dengan latanopros dalam menurunkan tekanan intraokular pada mata. Optimax dan Optimax Sirup untuk menjaga kesehatan mata pada dewasa dan anak-anak. Dengan komposisi antioksidan yang lengkap seperti bilberry, beta-karoten, lutein, likopen, vitamin C, vitamin E, serta zeaxanthin. Dengan sediaan kaplet untuk dewasa dan sirup untuk anak-anak yang sudah dilengkapi dengan rasa tutti frutti. Inilah produk Optimax Group kami, suplementasi mata yang paling lengkap di Indonesia. Mata adalah jendela dunia, mari kita jaga kesehatan mata dengan Optimax.